All right. Thank you, everyone, for coming to our vaccine town hall. And my apologies for the delay in getting started. We had some technical issues and really tried to get the live transcript going. So, on behalf of the Alliance for Equality of Blind Canadians Toronto chapter, we welcome everyone today to this event, Our Journey with COVID. Over to you, Minette.
Thank you, Christine, and good afternoon and welcome everyone to this our webinar on our journey with COVID-19. We thank you for taking time off your afternoon to join us for this very important discussion. This event is in partnership with the Alliance for Equality of Blind Canadians Toronto chapter and Center for Independent Living in Toronto, CILT, with funding from the City of Toronto. We especially want to thank our panelists for taking the time to share their experience and expertise with us this afternoon. Today's session will be moderated by Christine Zanier. Christine Zanier is a disability inclusion consultant with both corporate and community work experience. She has developed and implemented diversity and inclusion projects in employment and talent management for a Tier 1 bank. As an active member of the Alliance as an active member on the executive of the Alliance for Equality of Blind Canadian Toronto chapter, she has led consultations, focus groups, and events to promote equal opportunities for people with disabilities. Christine has a bachelor's degree in psychology from York University and a certificate in human resource management from Ryerson University. Thank you, Christine, and I hand over to you now.
Thank you very much, Minette, for that lovely introduction. And now I would like to share a land acknowledgement. In the spirit of truth and reconciliation, the Alliance for Equality of Blind Canadians acknowledges that we are gathered here today on land that has been inhabited by Indigenous peoples of this territory from the beginning. As settlers, we are grateful for the opportunity to meet here, and we thank all the generations of people who have taken care of this land for thousands of years and offer our recognition of the contributions and historic importance of Indigenous people. As I am in Scarborough, the land I am standing on today is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by the Treaty 13 signed with the Mississaugas of the Credit and the Williams Treaty signed with multiple Mississaugas and Chippewa bands. For those who can't see me, I am wearing a dark purple blouse. I wear glasses and have short brown hair, and I'm sitting on a gray chair. In terms of and my pronouns are she and her. In terms of our agenda, we will have introductions. We're going to share some Zoom tips on participating and asking questions, and there's going to be an interactive panel discussion, and there will be time for all of your questions. There will be a variety of ways that you can ask questions in the chat, and Rebecca will monitor the chat and create a speakers list for those who raise their hands. We want to provide everyone with an opportunity to share your voice. This is a very safe space where we can share our experiences. During the panel discussion, panelists from the medical community and those with lived experience with COVID will share their lived experience and vaccine hesitancy, long COVID, booster side effects, and fourth dose considerations. We're going to talk about our journey with COVID, where we are today, what we have learned, and what the future holds for us. We're going to talk and provide an overview of COVID vaccines, doses, benefits, and efficacy. We're going to talk about vaccination myth busting and common fears shared by disabled individuals with lived experience. And we're going to talk about the side effects of COVID vaccination and COVID infection. As you know, everyone is on mute. And here are some Zoom instructions for participating and asking questions. There are several ways that you can comment or ask questions with Zoom. You can add your question in the chat. You can mute or unmute on a Windows PC using Alt-A on a Mac, using Command-Shift-A, and on a smartphone by locating the mute, unmute button in the app. If you've dialed in by phone, *6 will mute and *6 will unmute. You can raise and lower your hand on a Windows PC using Alt-Y on a Mac, using Option Y, and by finding the raise hand button in the smartphone app under the More section. If you have dialed in by phone, *9 will raise your hand and *9 will lower your hand. Now, Rebecca is our host and she is managing the Zoom. Rebecca, is there anything you would like to say about the screens?
Just if anyone is in need of pinning capacity to see the ASL interpreters, please let me know and I will grant you that capacity. And you can set up in the top right corner on most devices a view option, but panelists and interpreters will be pinned for everyone. And if you have any issues, please feel free to send me a message in the chat.
All right. So we're going to get started on our panel discussion, and I'd like to introduce our panelists. So we have Dr. Rob Kozak. Rob, if you would like to introduce yourself.
Yes, hello everyone. My name is Dr. Rob Kozak. I'm a clinical microbiologist and virologist at Sunnybrook Health Sciences Center.
Okay, welcome, Dr. Rob. And Craig, if you'd like to introduce yourself.
Hi everyone, I'm Craig Maddy. I'm a research associate at UHN Open Lab based out of Toronto General Hospital and the program manager for the Friendly Neighbor Hotline.
Okay, great. And Nina, if you would like to introduce yourself.
I'm not seeing Nina on the call yet, Christine. I'm not sure whether Nina might be joining on a device with a different name.
Okay, she told me she was joining. Unless she's having difficulty. Let me check. All right, we're going to get this conversation started. Nina and Kevin will be joining us. And Nina and Kevin have both experienced COVID. So I'd like to talk and start the conversation about your own personal experiences, Dr. Rob and Craig, about COVID and being vaccinated. So Craig, if you could start us off.
Yeah, absolutely. So, one of the reasons that I'm here is that through our program at the Friendly Neighbor Hotline, we were supporting a lot of the vaccine clinics throughout the city in, hotspot neighborhoods, which was sort of large talking points. And, a large part of that work was going into communities, understanding hesitations, and trying to make things as accessible as possible. Being from the healthcare sphere and, having a background in medical science, looking at the vaccines, it really is something to marvel at how effective they are, especially in comparison to what we were estimating it could be. And I think, for us, a large part of, trying to encourage vaccinations was just having conversations about what the vaccines do, how effective they are, and just some of those basic things that I probably take for granted, being someone that works in the healthcare field, that I have a lot of information that probably or I'm able to access information that perhaps isn't widely available. And so I think just through those conversations, we were able to alleviate a lot of concerns, and hopefully today we can try to tackle some of those existing concerns that might have come up from anyone who is here on the call.
Okay, and over to you, Dr. Rob.
Yeah, so being a healthcare provider, I'm obviously quite pro vaccination, and here at Sunnybrook we dealt with the first case of COVID-19 in Canada, and we've been helping patients ever since throughout the pandemic. So for myself and for especially a lot of my colleagues who work on the front line in the ICU, in the emergency department, there really was a kind of a palpable sense of relief when vaccines were first became available. You kind of had this extra layer of comfort and protection, knowing that the data was showing they were efficacious, and it was something where I think it really made a difference. And as Craig mentioned as well, it was something where it was incredibly impressive how fast we were able to get these vaccines and get them out, and especially early on rolled out into the right populations who could really benefit from it, right from the beginning.
I wanted to talk about the fourth booster because there hasn't been a lot of discussion about the booster since the election, and I wanted to get your thoughts on it.
Sure. Who do you want to go first, myself or Craig?
Yeah, Rob, you can go.
Okay. So I think this is something where the data is kind of evolving on this as well. There's probably a good place for these vaccines amongst special populations, people whose immune system might be a little bit compromised, people who are elderly. There's data suggesting that a fourth booster just keeps up their level of protection, and probably most likely give them the protection from infection. It's important, I think, to differentiate at this point that the vaccines we look at them for protection, not just from infection, but also preventing against hospitalization and mortality. So 3 doses is doing an excellent job of that, and that 4th dose will probably give a little bit of an add-on and additional protection against infection amongst certain populations. I myself, I will wait for guidance to say that whether I need a booster or not. I'm relatively healthy. I don't think I can say I'm young anymore, but I probably don't need that fourth booster. And I guess from the global perspective, there are a lot of places in the world that are still there. People are still waiting for first dose. So I think there is a place certain people probably do need a 4th booster, but I don't think we've seen convincing data necessarily that everybody needs one, but that can change.
And I want to echo what Rob hit on. I do agree that there are populations that could benefit greatly. I know, for example, we work largely with seniors, specifically low-income seniors, many of which have sort of multiple illnesses that they're dealing with, who could greatly benefit from a 4th booster, and who really fall squarely within that criteria. I know even, for example, for my parents as well, who are older, they do also fall within that criteria, and they're definitely also going to get boosted up. And so I think, as the data suggests, there are specific vulnerable groups that really can benefit from the fourth dose, and has been made available in small amounts to those groups. And I think as with a lot of this, as the data evolves, we'll see how that criteria changes.
I'll just add one more thing too. I think that there's a lot of work being done in the scientific community right now to determine for the fall what might be if we need an Omicron specific booster. And there's new information coming out from Moderna saying that their booster may confer additional protection. So COVID might become something like the flu, where we need a booster that's tailored to whatever virus is circulating. So that could change up, our recommendations entirely. You ask me in a couple months, and I'll say, yeah, absolutely, I need to get that booster because it protects me against the virus that is currently circulating. But only time will tell.
And Dr. Rob, as a microbiologist at Sunnybrook, you've experienced COVID upfront and personal. How did you get involved with researching COVID?
So I am before I started my position here at Sunnybrook, I actually worked in the at the National Micro Lab. I've always had an interest in emerging viruses and zoonotic viruses. I've worked on things like Ebola and Zika virus and a number of other really unusual named viruses. And then when I started here, I had a research program on virology. And then since Sunnybrook had the first case, there was a lot of kind of real world clinical questions that needed to be answered. And so it just was something, well, a natural fit. I said, well, let's see if I can work with lots of great people and try to answer some of those questions. And so I kind of get involved in it because there's a lot of overlap between the research and what I do in my day to day. Anything from trying to improve testing to I've been in part of vaccine and therapeutic trials, assisting with those. So it's great to be able to use research to try and answer things that where we can see people help directly.
And what has been some of your key learnings that have come out of the virus? We've been there's been 6 waves of it.
Yeah, I think it's well, because we this is only booked for 2 hours, so I won't go into all the stuff. I think for me the biggest point from this is that this virus continues to surprise us, and that the worst thing we can do is be complacent. There was in my own thing that my learning evolved. I remember when this started, I didn't think asymptomatic transmission was possible, and then someone showed with good epidemiology and good data that it is possible. So I think that my learning has always been to sort of always keep an open mind, follow the science, and that not to think that just because we've solved something that it's that we can sit back and just wait. This is something we have to always try and stay one step ahead.
And what about Craig? What have been some of your key learnings?
Absolutely. And I mean, one of the biggest learnings, and this may come as no surprise to folks on this call, is that one of the thing we don't do enough in terms of accessibility, both from a language perspective and from even a physical disability perspective as well, especially in some of these pop-up clinics. So one of the biggest things that I had tried to work on with some members of the community was to put together some of these guidelines, basically in a little playbook for vaccine clinics, so that there's a clinic popping up in a school, they're making sure that simple things, even that there's a ramp for folks who can't make it upstairs, there's appropriate signage, that where it makes sense, rooms aren't too loud, and things along those lines. And I think that was a really big learning for myself, even trying to understand how we can modify on the fly some of these spaces. In parallel with that, there's also a lot of language barriers and cultural barriers that we needed to be particularly sensitive to while we were going into some of these into some of these communities that we had never been in before. We had some clinics in schools, but we were also running clinics in apartment buildings. So we're entering into someone else's space. And so it's a matter of how are we ensuring that we're being respectful when we go into these spaces as well. And so those were all very important learnings to me because, you know, I don't have a sight line into, I apologize for my dog.
It's okay.
You know, I don't have a sight line into all of these neighborhoods. So just going in and being open-minded, being sensitive to those needs was a very big learning for me as well.
And thanks for that. Dr. Rob, there's other viruses that actually act similar to COVID. Like it has like a long COVID experience from some of the research that I've been doing.
Yeah, so so certainly, I mean, that when you talk about things that were interesting to learn about COVID, definitely finding out that there is the syndrome, post-acute sequelae or long COVID, as it's called, has that was certainly that was very interesting and quite a surprise. But you're correct. There are a number of other viruses where we see this, you know, this sort of syndrome that occurs after the acute phase. So after you kind of recover from the you know, usually a couple of weeks, you recover from most viral illnesses, then you sometimes have ongoing persisting symptoms. So a common one that probably people are familiar with is Epstein-Barr virus or mono. When you get infected with that, usually when you're a teenager, and sometimes the symptoms can persist for you know, for months. But interestingly, there have been other viruses like even influenza. There have been people who've reported symptoms to be, you know, to be ongoing and not resolving, you know, months after their initial illness. I think that we miss out on a lot of these other ones because often we don't have large enough sample sizes to see it. You know, another thing when I was at the National Micro Lab is they noticed that in the West African Ebola outbreak, there were patients who had ongoing symptoms after they'd recovered from the acute phase. They had joint pain, eye problems, and we'd never seen that before because we'd never seen an outbreak this big. So I think that probably one of the interesting things about long COVID is that it will really kind of encourage us to go back and look at other viruses and sort of say, do we see these sorts of symptoms and this kind of ongoing persisting illness or disease after the acute phase of other viruses too?
And Rob, is there scientific data on the percentage of cases that actually develop into long COVID?
Yeah, so I mean, the problem with long COVID is we still don't have a great definition. You know, we're 2 years into the pandemic and we still don't have a great clinical definition. You know, roughly it's the kind of the common things everybody sort of agrees on is it's you know, a couple of symptoms that are usually persisting for greater than 12 weeks after your initial infection. So because we don't have a firm definition, the percentages tend to vary depending on the study. So I've seen ones where it's as high as, you know, 30 or 40%, and some that are, you know, as low as 10%. But even if it's 10%, that's significant. I mean, we've had, you know, over 3 million cases of COVID-19 in Canada. So 10% of that is 300,000 people. 300,000 people who are potentially suffering from long COVID is a huge health concern.
So that's really interesting. I didn't know that it was 10% for long COVID. Now, if you were vaccinated, you have a lower risk of long COVID. Is that true? I mean, I read that and
yeah, and I could maybe even put it in the chat, or I could send it to you later. There's a great paper in Nature Medicine that came out recently showing that they looked at data from the US, and they showed that, you know, vaccination does decrease the likelihood of developing long COVID. I mean, that's it's unfortunately it's not 100%. You can still. It significantly decreases the incidence of long COVID. I mean, it makes sense. You know, vaccines protect you potentially against infection. Certainly can protect you against more severe disease. So I think it makes sense that, of course, they're going to protect you against the post-acute syndrome.
Rob, that would be great if you could put it in the chat. I'm going to add it onto our resource document that I'm going to share with everyone after this meeting.
Absolutely.
Okay. And Craig, I want to bring you into this conversation. So what has been your experience? You know, you were talking about leading volunteers and pulling together resources for pop-up clinics. What is it like right now in the field?
I think after the last wave of booster shots, things have slowed down a bit, largely because the team is waiting for more guidance, like Rob was talking about, on fourth doses. And the volume of vaccinations required for people who meet that strict criteria is pretty small compared to the bigger population. One of the things that has changed a lot is that vaccines have become more available at local hubs, so pharmacies and family doctors. That doesn't eliminate the need for pop-up clinics in some neighborhoods like Jane and Finch and Rexdale areas. But it does mean that we can still run those clinics on a much smaller human resource capacity. But the team is still, the teams, at least at UHN, we're still thinking and talking about the potential need down the road. And I was even having a discussion, last week about potentially re-engaging some volunteers to help with clinics. So we're in a planning phase right now for what may be to come. But as of right now, things have slowed down, especially compared to the first, second, and third doses.
I'm just closing my window. People are lawnmowing out there. So let's talk about some of the myths and misinformation that's out there. We talked about, the fourth booster, and my understanding is it was for the 60 plus community, and then it just completely fell off, and there hasn't been a push anymore. I think it's moved out to the fall. And Rob, what is your thinking around this?
Sorry, Christine, you cut out for a second there. Can you repeat the question?
Sure. I said, let's talk about some of the myths and misinformation that's out there.
Wow. Yeah. Again, where to start? We don't want to use the whole 2 hours. I mean, I've just seen so much from different people I still see things about people saying COVID's a hoax, that the virus doesn't exist, that vaccines don't confer protection. I even read the most recent book by Bill Gates, who assured us that there are no microchips in the vaccine, that he's, but there's just so many, there's so much misinformation. A lot of it is around the vaccination or treatments that, there was a lot of talk about different types of treatments, like things like ivermectin, that people said, well, that worked, even though clinical trials showed that it didn't. And often the unfortunate thing with sometimes with stuff like that, especially when it gets taken up by the popular media or by influencers on Twitter, is that people will say, and we actually had unfortunately cases here in who were hospitalized because they thought that ivermectin would protect them from COVID, and they decided not to get a vaccine, and so they ended up getting hospitalized, and probably vaccination would have protected them. But perhaps I think Craig is probably in better position to comment on a lot of the sort of the vaccine information. I think he's a lot closer to the front lines in that sense than I am.
Yeah, happy to hop in. I think you hit on a lot of key points there, Rob. And I think there are a couple of tiers to, let's say, misinformation that we can tackle. I mean, one of the big ones that's very in your face, really is around sort of these conspiracy theories and what is in the actual vaccines themselves, thinking that there are sort of hazardous chemicals, which there aren't in the contents of the vaccine. Some other ones actually are a little bit more are pretty reasonable when you consider them in the context of, some folks, there are cultural considerations around vaccinations. So for example, during the booster clinic, or sorry, the dose 2 clinics. It happened during the month of Ramadan. And so there was a lot of issues and misinformation saying that, you can't get vaccinated during Ramadan and things like that. And so what we had done was we worked with local imams to prepare some messaging and materials to put out there that actually helped a lot of folks sort of shift their mindset. And we actually, that was when Michael Garron Hospital had run that really big vaccine clinic that did, I believe it was 10,000 doses overnight. So, I think simple things like that really help to unpack some of the issues around misinformation. Another big source of misinformation was that one dose was enough to protect you. And I think a lot of folks thought that you get one jab and you're good to go, not realizing that the vaccine's full effect comes with 2 doses and is topped up with your booster and things like that. And I think a large part of this comes from some of the miscommunications. Science is an evolving field, and as Rob has already touched on, new information is being made available every day. And sometimes it's confusing when you hear one thing and then you hear another thing, and it sounds like there's a little bit of flip-flopping between some of the data, but that's science at work, science at its best. And so that was another big piece that we had to educate a lot of folks on, that one dose isn't enough. You need multiple doses to get the full effective vaccine. And I think when you look at even the hospitalization numbers of vaccinated versus unvaccinated, first dose versus second dose versus third dose, you kind of see that those who do take the full course of the vaccine are much better protected, especially against hospitalization and death. And that's the big thing. I'm trying to think if there's any. I guess one other piece about vaccine misinformation that I will just sort of touch on, and it's kind of a bigger issue, is that one of the biggest things that we saw was that folks who were maybe on the fence about getting the vaccine, a large part of it comes from actually their social circles. So they're perhaps in social environments where their friends, their family don't believe in the vaccine, and choosing to get vaccinated is sort of a social affront. It will sort of, they'll lose their social network as a result of it. And I think that was also a big problem that we were seeing, that folks want to get the vaccine, but we're feeling social pressure against it. And that's not an easy thing to really untangle with folks. It's something that really takes a lot of time to sort of educate and work through. And so that's sort of a more, let's call it an existential problem that exists with some of the vaccine misinformation.
Okay. And what about side effects, from boosters? As people were getting boosters, I think Pfizer was putting out, you may have this, you may have that, Moderna as well. I actually had a third booster shot in January, and I had severe side effects. I had trouble breathing. When I went into the hospital through emergency, they said, "You're having a panic attack." And I said, "I don't know if I'm having a panic attack. I am having shortness of breath. I received the booster, like at 10 o'clock this morning. And at 3 o'clock in the afternoon, I seriously had trouble breathing." So the first thing I did was call 911, and they came and checked me out. And when I went to the hospital, they said, "Possibly you have COVID. This is why you have this side effect from your shot," because I had 2 vaccines, both with Pfizer, and had very little reaction. Well, I had some reaction. I had a little bit of symptoms, but nothing extreme as the third booster. So I want to hear your thoughts on this. And Dr. Rob, of course, I'm going to call on you because you're the doctor. So
Well, so I should clarify. I'm a microbiologist. This is definitely something that
I know.
yeah, there are certainly experts in the field, and so there, of course, there are individuals who've reported side effects from the vaccine. So it does occur. the risk of it is actually fairly low. Christina, I think you're just unlucky. You should have bought a lottery ticket that day.
Yeah. Okay.
But you know, like one of the ones that was reported quite a bit was myocarditis, for example, which is inflammation of the heart in young men, for example. And you know, the odds of that are about you know, one in 50,000. So it's extremely rare for a lot of these side effects. And obviously it's very unfortunate for the person that when they're experiencing it, and Christine did the right thing by, you know, calling the paramedics and going to the hospital. But I think we always have to balance that out with the benefit that comes from vaccination. And also we always have to be careful. This is a problem in medicine, is the, you know, the false attribution. You know, sometimes people will, you know, there a lot of the side effects are, if you don't experience them within the same day, then they're likely not related to vaccination. So, you know, if somebody says, well, I got vaccinated on Monday and then on Friday I have back pain, well, that's probably due to something else. And we really have to make sure we don't sort of falsely attribute one thing to another. But it sounds like in your case, you had some pretty bad symptoms or pretty bad side effects. I'm glad you're okay.
Thanks for that. Yeah, I'm definitely okay now. It was pretty scary, that's for sure. Now, I just want to, Robert, you have your hand up, and I'm wondering if your question can be asked when the panel discussion is over, or if you'd like to put something in the chat. No? Okay.
Okay.
Okay, go ahead.
Chat.
You'll put something in the chat for us, Robert?
No, I won't put something in the chat. I don't know how to do it. I can wait when you start the questions.
Okay, perfect. That would be wonderful. So masking, this is, I think, a very good conversation for us to have. I don't know if it's misinformation, but do masks work? A lot of people think they don't work. I know we're in June, we're outside. I just heard on the news that as of Saturday, they're talking about taking masks away. And I don't know, I was floored with that comment. I do find in my neighborhood that quite a few people wear masks, but it is all over the place. And I know public transportation and healthcare are the two settings where masks are absolutely mandatory. So what are people's thoughts on masking?
I can get started on this one. I think, you know, bar none, it's clear that masks are effective. And it's one of those things that, you know, when they work really well, you don't necessarily notice, because it is sort of a preventative measure. That being said, you know, we can't control what the public policies say, but, you know, one of the key elements, I think, around masking is, you know, personal responsibility and protection. I think outside of the Western world, and I'm sure this has been said before, masking when you're feeling unwell has just been cultural practice, and something that I hope persists even beyond the pandemic. I think there are a couple of good things in that sense that have shifted, not only sort of masking when unwell, but I know previously, before the pandemic, if I was feeling, you know, sniffly, I would still go into work. And I think that cultural shift, that very necessary cultural shift, is happening as well. But I think that there is a lot of evidence to demonstrate that masking is effective. And going forward, you know, I think it, you know, there is a personal measure to it. I know in many situations I still wear my mask. I just out of my own personal comfort level. And I think many others will as well. I've also noticed, Christine, very similarly, that a lot of folks in my neighborhood still do choose to wear their mask. And so, yeah, I think it is effective, and going forward, it's going to become a part of our culture in some measure.
Yeah, I'll just echo what Craig said. There's no the science supports it, and there's no question that masks protect both the that protects you from getting infected, and if you happen to be infected, obviously protects others around you. So I mean, I think it's something where, I mean, I work in a hospital, so for me, masks are part of everyday life. And I imagine will continue to be. So I also take the TTC to work. So I'm just when I'm at home is when that mask is coming off. And I can appreciate for many people, it probably is something where there's a little bit of, maybe a little bit of fear or hesitancy because, when everybody in public starts taking their masks off, perhaps you want to keep yours on, and that's totally fine. Just because there isn't a mask mandate doesn't mean you can't wear one. But it can probably be, it can be scary. I was a little nervous the first time that I went out to a restaurant with some friends and we didn't have, masks and sitting around people. So it's all about people deciding their own level of comfort when they want to keep wearing a mask. And I think in the fall, it's definitely something that people want to consider, because it's not just COVID that a mask protects you from. It protects you against flu. It protects you against the, common cold viruses, protects you against enterovirus, all these things that can also make you sick. And, I've having, gotten respiratory viruses before, it's not pleasant. That's not how I would choose to spend 3 days of my life. So, but it's, of course, it is people's choice whether or not they want to wear them going forward.
Well, I know personally I'll be wearing mine going forward. And traveling, I think it's really tricky because I think different countries have different policies around it and they're changing all the time. Some countries you have to take a COVID test before you enter, some you don't. It's very confusing and there's different guidelines.
It's a bit of it's unfortunate. It's a tough situation because it would be great if everybody kind of just was using the same playbook, but different countries have different different priorities, and their governments make decisions at different different rates. I mean, even here, I think there are a lot of things that probably they will get rid of. For example, the testing at airports, they've been gradually reducing it, and my suspicion is probably by the fall we'll probably eliminate testing for travelers, because it isn't supported by much data to say that it really makes a difference in controlling spread. In terms of when both my wife and I have traveled, going to scientific conferences and that sort of thing. We make some of our travel decisions based on things like, is the area we're going to, do they require a testing or proof of vaccination, because that makes us feel more comfortable. And again, I think this will be people's own decision, their level of comfort, based on the guidelines and potentially restrictions that are in place at a destination. Do you feel comfortable going there with what's in place?
Yeah, and just to add on to what Rob said, I can actually speak to some personal experience here as well, where I was, my dad was preparing to travel, and so I was helping him to figure out some of those recommendations. And actually, so he left earlier this week, and just a few days prior to his departure, they changed the entry requirements to enter into the country he was going to, and so. It's tough to stay on top of all of that information. It's a lot of information to take in, and there's no centralized place really to keep track of it all. And so, unfortunately, I think travel is one of those areas where you have to be just a little bit diligent about looking up the requirements of the travel destination, and like Rob said, sort of traveling within your comfort levels. And I think much like with just everyday life, the same rules kind of apply to travel as well, in terms of masking and comfort levels, even when mandates may be dropped. Yeah.
So where do we go in the future with COVID? I think Dr. Rob, you said we're going to be living with this for a long time. How do we deal with this?
Yeah, I know we'd all hoped, and I was one of those people at the beginning who was hoping for the COVID zero, that we'd be able to that it through vaccination and through various public health restrictions that we would eliminate it. Unfortunately, I think it's going to be an endemic virus, which means it's going to be something that will continue to circulate much in the same way that flu does. I think it will probably be something that will be like a lot of our other respiratory viruses, probably worse in the fall and winter, sort of hanging around in the spring and summer, but definitely worse in the winter months. And I know that's not the news anyone really wants to hear, but I try to be ever the optimist, and we have great tests. We have really good vaccines, which people are still working on to improve and to make better. We have antivirals and other therapeutics to help treat people who do develop infections. So it isn't, and we have great things like, we know social distancing and mask wearing can help protect us. So we have a lot of tools that we need to live an quote unquote normal life with COVID, and it'll just be our decision whether or not how much those we choose to follow, and whether or not we integrate a lot of them into our lives, and make sure that the people who make public health decisions also keep that kind of stuff in mind. As an example, I would love it if during the worst part of the respiratory virus season, if again they made masking mandatory in not just on public transit, but also maybe in other public settings. That's just good for everybody. So those decisions will be those are decisions above my pay grade, though, unfortunately.
Okay, and Craig, what are your thoughts?
Yeah, I think as a companion to a lot of what Rob said, there is some social shifts that need to happen in order to make all of these things possible and more acceptable. When it comes to things like choosing to work from home, or a hybrid model of work. A cultural shift around, if you're feeling unwell, just taking the time away from work, but also having the supports to do so, paid sick leave, and more flexible schedules as well on the labor side. So some of those shifts I think are really important, and those conversations need to happen, as well as normalizing seeing folks just wearing a mask when they're out and about shopping or traveling, even in the absence of a mask mandate, and that being a personal choice that is acceptable for anyone to make. And so I think slowly we're starting to see some of these take root, specifically around masking. And hopefully we continue to have conversations, especially around labor, because I think that's a really, really big one, where the folks who really need the paid sick supports most don't get it. And so these are social conversations on multiple levels that we need to be having as we move forward into this sort of future with COVID.
If I can just add something, I'm really glad that Craig touched upon that point about the paid sick leave. I think we have learned over the pandemic that COVID does not affect everybody equally, all populations equally. We know that there are that people who are socially disadvantaged, were worse. Those neighborhoods were worse affected in Toronto than more affluent ones. We have to make sure going forward that we don't make those same mistakes and let certain communities bear a higher burden of the brunt of it, as we did in these 6 waves. Because we have the science now. As I said, the vaccines, the drugs, COVID is becoming less of a science problem and more of a like dealing with the what we call the social determinants of health. And I think that is the stuff we need to always keep in mind, and we always need to push forward on.
I think that's very true. And I think we also need to keep a very positive outlook. We're now in the summer, we can get outside, we can be with our friends, we can be with our family, we can be safe. And I think that, that's an important message as well. And I think vaccination, may not be out there in the news, but it's definitely important. And if you're immune deficient or elderly, definitely look at having the vaccine. So Rob and Craig, thank you so much for all of your comments and discussion. And I'd like to hear from the audience. Rebecca, are there questions from our audience?
So Robert, if you would like to unmute and ask your question, you can go ahead now.
Okay, my question is that he mentioned the fourth booster. It's 2 boosters after the 2 shots. I don't know if that was misinformation or whatever. And the other thing I have to say is that if you want the COVID to go at bay, you need to vaccinate all the world, like Africa. You need to send vaccines to Africa to cut down the variants.
Couldn't agree more, Robert. You said it perfectly. It's the fact that there are countries in Africa and in other parts of the developing world where even healthcare providers, the people who are caring for the people suffering from COVID don't necessarily have access to vaccines is something that we in the developed world need to, like, we can't put our head in the sand, and this is something that every Canadian has the power to to be involved. This is push the people at the top, push the people, push your elected leaders for it, like hold their feet to the fire. There's no reason that we should be offering every single Canadian a 4th vaccine dose when there are people in the world who haven't had one.
Yeah, okay.
Did
And the other
anyone?
thing is when I traveled, I had to get a COVID test. So I didn't mind doing that.
Did anyone want to clarify about Robert's question about the language, 4th booster, booster dose? We kind of use some different terminology, and I know it hasn't been consistent how many vaccines people should get has been described.
I'm happy to take the first swing at this, and Craig, please jump in to correct me. It's been challenging because the 2 dose was we had those 2 doses because that's how our clinical trials were done, and all the efficacy data was based on that. And so one of the things about vaccines is they generate antibodies for a relatively short period of time, and then they generate T cells, which give you that protection against severe disease for a much long period of time, years to potentially even decades. So the idea behind giving a 3rd booster or a 3rd dose was to bring these antibody levels up to protect you against infection. 2 doses probably protected you well enough against severe disease, but the 3rd dose protected you against infection by bringing up your antibody levels. And I agree, it was bad to call them boosters because then it's the next one is like, we don't call our influenza vaccine every year a booster. It's just your annual flu shot. But this, unfortunately, this is one term, gets into the, into the common vernacular, the public sphere, and we kind of go with it.
Yeah, and just to echo Rob's point, I agree that it's tough when something sort of takes root. On our end, we, for consistency and clarity, identified it as 1st, 2nd, and 3rd doses, especially in the cases where maybe we were running a 2nd dose only clinic, in the cases where folks were, 3rd doses were available, but people didn't have the opportunity to even get their 2nd dose yet. And just making sure that we were creating space for folks to stay on the proper course of vaccinations. And so, at least internally, we tried to clarify in that capacity, but definitely it was quite confusing, I would say, for a lot of folks.
Thank you. Linda, if you would like to unmute and ask your question.
Yes, thank you very much to both speakers for providing this informative session. I actually have two questions for Dr. Rob. First is when you talked about the thing with eliminating testing in airport, and you kind of mentioned about how testing does not really make a significant difference on COVID transmission. Can you please just elaborate a bit on that or that statistic as to why testing may not be that important moving forward?
No, okay, sorry. Yeah, that's a good point, Linda. Sorry that I don't want my comments taken out of context. So testing is a great way for us to control spread of the disease, and it's been amazing that we've had things like assessment centers and rapid testing through antigen testing available. That has really helped because you can do especially an antigen test. You can do an antigen test at home, realize you're sick, and not go out to the party or not go to work. And that's really critical. Testing at airports is probably not really useful. So you test incoming travelers when there's no disease in a country and you want to make sure that nothing is imported. But there's about midway through the pandemic, we looked at genomic data. So we looked at all the sequences of viruses that had been done, and it was estimated that only about maybe 2 or 3% at the most of viruses were a result of importation. So once the virus is circulating, as it is, when we have, in December, we had sometimes, like in Toronto, I think we had something like 11,000 new cases a day. If someone comes in on like it brings one in from traveling somewhere else, it doesn't really it's not changing the sort of the epidemiology there, and the value of doing it. And this isn't my personal thought. This is from real public health experts. The cost and effort that's put into screening people at the airport probably could be better used somewhere else where it would have much more of an effect. So testing works. I just don't think testing returning travelers at the airport is actually doing what we hope it will.
Okay, yes, that does bring more perspective into the issue. Another question I have for you is that from my understanding and what I read a lot from news, we're saying that nasal vaccine might be more effective as a form of COVID vaccine as, the virus enters through our respiratory system. Do you see Canada having nasal COVID vaccine in the future?
Yeah, I hope we do. There's some really cool work being done by a researcher at McMaster. His name's Matthew Miller, Miller. You can Google him and look up. I think they're even doing clinical trials now. So the idea is that the way we give the vaccines right now, they're delivered systemically. What we really are trying to, the holy grail, the best vaccine would be one where it develops not just a strong immune response throughout your body, but also a very strong antibody response in your upper respiratory tract. So lots of antibodies present there that can neutralize the virus before it even infects. So that's when people are doing nasal vaccines, they're trying to really stimulate that local immune response in your nose. And so I know people are looking at it, and if they show it works, I can assure you I'll be the first in line to get one.
Yeah, for sure. I actually came from McMaster too, so that was something that a lot of my profs were talking about. So it's good to sort of see what's your perspective on it as well. Thank you.
You can keep us posted when they make progress on it.
Yeah. Thank you so much.
Thanks, Linda. Suchita, if you want to unmute and ask your question, please go ahead.
Cool, thank you. I guess this question could be for Rob or for Craig, but I've noticed in the last few months the City of Toronto's antiviral treatments page has been updated a couple of times, but there's still, I'd say, it seems to imply that the antiviral treatments are primarily for people who are at high risk, as opposed to for the general population. Could you speak to why that is, and why there seems to be a lack of information about the other treatments available to people based on their other conditions potentially. It feels all very vague right now, why that might be. Craig, you're muted. Excuse me.
I can, thank you for that. I can hazard a starting guess and maybe throw it to Rob, but I know one of the big barriers to making antivirals publicly available is just cost. And whether it will be provincially covered or being paid out of pocket. So I think that is probably one of the barriers. In terms of efficacy, I might defer to Rob on that one, but that's at least part of my understanding.
So the question you're asking about why the criteria for giving antivirals seems to be changing?
More why it seems to be so restrictive and less available to the public. There's been, obviously a human grade ivermectin was a thing that people were trying, but one of the reasons they did that is because it was just available. So why aren't antivirals simply that available, I guess is my question.
So that's a good question. Look, I don't disagree with you. If you compare how things are here to how they are in the States, where they have a lot more access to antivirals and monoclonal therapies. I mean, again, it's an interesting question to ask the people, the people in charge why they're not more widely available. I think that in terms of access, a lot of it is based on kind of who will benefit there. So if you have relatively mild symptoms and you're relatively young and healthy, then you probably won't derive any benefit from the antivirals. It won't decrease your symptoms. You already are not at risk for hospitalization, so it won't protect you from that. Because the amount of doses I think it Canada had, I don't know if it's changed, but initially we didn't have a huge amount, and so there was the idea that we need to prioritize it for those most at risk of severe disease. There's also restrictions to the drug like Paxlovid, for example. If you have if you're on other types of medication, the drugs can interfere with each other, which can often lead to like potentially very serious side effects. So, and if you have certain kidney issues, I believe as well, that can affect the how the drug is metabolized. So there's some of the reasons are in there because we don't want people who would have serious side effects from it to get the antiviral. But I think there is also a bigger question to ask is why we aren't making them sort of more widely available now, especially when there's not as much of a demand. So there's a science side and there's a politics side. I can really only speak to the science side.
Mm-hmm, mm-hmm. Thank you for that. I think part of my question is coming from being in the field, and one of the critiques is that there just isn't enough information about any of this out there, and that makes people suspicious. And so if there are side effects and if there are medications that you should take it with, I at some level I don't see why that's not publicly just on the website. But I think just as a follow-up question.
Well, sorry. Let me just address that. So sure. It's not that it's not publicly available. You can go and look up the like the FDA and even Health Canada's all their information on it. But it's like I think the FDA's short version was like 16 pages. So it's not something you can easily just kind of dump onto a website. They're absolutely not hiding anything about contraindications. It's quite extensive what they have.
Sure. No, sorry, I wasn't trying to imply that Paxlovid, the data on that was hidden. It's just that on the City of Toronto website, it's not immediately apparent why you wouldn't be able to have it. That's really what I meant. But I appreciate your clarification. A follow-up on that, came across a lady who had negative reactions to the vaccine and claimed that she had to pay for all the treatments to those out of pocket and that they weren't covered by OHIP. Do we have any clarity on what that is right now, and whether there's a way to help folks get coverage for anything of any negative side effects?
I don't know, Craig, if you're, I'm not this may exist, but I mean, I think this would, you'd probably have to ask a family practitioner. They might know some of the drug benefit, but that seems unusual. But if she had side effects, that they would charge her for medication. Is that for?
Well, she needed medication to manage the side effects of she had severe swelling in a limb in her leg, and that hadn't gone down after 6 months, and so that needed continuous treatment, and OHIP wasn't covering her anymore, and I was what I received, at least.
Yeah, I'm sorry, I'm not enough of an expert in kind of the the drug reimbursement policies and that sort of thing in Ontario. I don't know, Craig, if you have any insight on it.
It's one of those things that I think is very specific to the situation, because there could be a couple of things, like perhaps either she didn't meet a certain criteria, perhaps the drug that was needed isn't available in Canada and it had to be brought in, so that comes at a cost as well. So it's one of those things, like Rob said. I think it's specific to the situation, and you really have to get into the weeds of OHIP pricing to try and figure out why that may be the case. So I guess it depends on the severity. I personally also am shocked to hear that, but I do know that situations like this do pop up, unfortunately, within the system, because of how kind of odd and rigid OHIP can be at times.
Yeah, I think the problem was that she was mandated to get vaccinated because of work, and then, not feeling like that she's covered for any of that out of it. Her having done her part and then feeling left out of the system. So yeah, I was just wondering if we had any clarity about where she could go to even appeal that kind of thing.
You know what? Unfortunately, I'm not sure. I can perhaps ask around, and if I do come across any resources, I'll send them to Christine to include in some of the material after the fact.
I know there is a federal program that was, and I just know about it because I saw it in the CBC, for people who have adverse effects from vaccination, because they've approved the first claimant, or of all the claimants, they've approved one, and we're interviewing this gentleman. So that might be something that they could look into if they. I know nothing about what the requirements are for the program, but that would be my first Google search if I was in that particular situation.
Thank you. I wasn't aware of this.
Thank you. I'll also add, depending on where the drug coverage is coming from, if it's through a work plan or through Trillium, those systems will both have appeals processes of how you would follow up if a claim for coverage was denied. So take a look at what the insurance says too.
Amazing. Thank you.
Okay, Musawi, if you want to unmute and ask your question, please go ahead.
Yeah, thank you so much. My name is Mursal. I'm community health ambassador with Afghan Women Organization. My question is if it is possible to give us a general information about the safety and immunity of each dose of vaccine, because people are asking in the community. For example, I got the third dose. For how long I will be protected and my immune system will be okay? Thank you.
Yeah, so there are so a lot of this is it's not a simple. There's not just a simple answer. The simple answer is your third dose will protect you from hospitalization and death. There have been a number of studies that are showing that even against the Omicron variant, the protection is quite high. I don't think it's I don't think it's lower than like 85%. It's quite good. It becomes a little more complicated if we encounter a new variant. We're also not sure how long that efficacy will last. The data so far has shown that 6 or even 9 months out that you still have great protection, the very high protection against severe disease and mortality. But I can't tell you that it'll protect you 2 years from now, because we've only had COVID with us for 2 years. So a lot of this stuff is we're kind of learning on the fly. And so it is entirely possible that, that data may suggest that there is a need perhaps next year for another dose in order to keep up the vaccine efficacy. But what we know right now is 3 doses in healthy people with few comorbidities is very efficacious at protecting you against severe disease and mortality. I mean, if you just Google vaccine efficacy, New England Journal of Medicine, you can see all the clinical trials that have come out recently, including the ones that evaluate efficacy against the Omicron variant.
Great, thank you so much.
No problem.
I'm just going to read a question from the chat, and then we'll go to our next question. This question is about the mask mandates ending June 11th. Does this mean that no places in Ontario will require masks anymore? For example, does it mean that the TTC and hospitals are no longer going to be requiring people to wear masks?
Hospitals will still be requiring masks.
Yeah, I have to look into specifics of the TTC as well, but some special places, like for example, like Via Rail and airlines will probably have their own individual mandates. So I think for things like transportation and, as Rob said, definitely hospitals, you would need to either approach them or check out their masking policy prior to entering. But I think that will probably broadly apply to more social settings where the mask mandate will be dropped. But unfortunately, it's still, there's no clear and simple answer. But I think generally speaking, you can probably assume that places where there would be sort of natural crowds and where we've talked about masking being important, like transportation, will probably still have a mask mandate in effect to some degree.
Thank you. That's a helpful reminder that businesses and organizations may still implement masking as a practice and requirement to come in, whether or not there is a mandate happening. Dan, do you want to go ahead and unmute and ask your question?
Yeah, real quick. I'm faced with a big dilemma. I have a friend of mine we've been friends for 30 years plus. And a couple of years ago, his mom, who was 70 years old, he felt, really concerned, and he was listening to the media reports about people being more higher at risk. So he really urged his mom to go and get the vaccine. Now, I don't know her full medical history, but she may have been immunocompromised. And long story short, she got the shot, and within 2 weeks, she got another illness, or an illness that actually took her life. And now my friend, who knows that what work I'm doing now, has, he won't even speak to me. He thinks I'm part of the enemy. And he is an example of how an anti-vaxxer is created. So he was on board. He tried to get his mom to do that. She acquiesced to it. Now he feels that he's handling the guilt of asking her to do it, and he feels directly responsible for her being dead now. And now he is like a rabid advocate for fighting, like he's a rabid anti-vaxxer kind of thing. I don't know how I'm supposed to enter into a discussion with him. I don't know. Do you have any suggestions? I'm not asking you to save my friendship, but he's not the first person that has stories that they feel have been connected to getting a vaccine and then had to deal with that kind of, do you understand where I'm coming from? And do you have any kind of suggestions? I would appreciate it.
Yeah, thank you for sharing that, Dan. That's a tough situation to be in, and one that I am familiar with. I think we've encountered a lot of folks in a similar position to your friend, throughout our work. And I mean, the only answer I can really provide, and the one that has sort of worked for us, is, in order to really meet folks where they are, I think it requires time and patience. I can even speak more specifically to someone in my own family who was in a similar position. Obviously I'm running these like vaccine clinics, and they have their own hesitations around vaccinations. And how I personally handled that situation was pretty much whenever it came up, just hearing them out and pushing back essentially with some first affirming their feelings of concern, because they are afraid, and much like your friend, he is going through and processing a traumatic experience. So acknowledging that first and foremost, without pushing them away, and where it makes sense to gently insert some, whether statistics or facts, and just very calmly stand your ground in that regard. And slowly over time, I think it begins to open up that conversation. Because what has to happen is, one, of course, there are facts to be communicated, but two, over time, they need to also work through and process those emotions and hesitations. And for me, it took, I would say, like, 4 to 6 months, and that family member ended up getting vaccinated. But it's one of those things that's really a long game, which isn't always easy when you're trying to move quickly during a pandemic. And yeah, like I said, there's no easy or quick answer, but that's sort of a model that works for us, that worked for me personally. And obviously, I think the situation is very complex, and I think you're a good friend for also still being concerned about your friend and what they went through. And so yeah, hopefully that's helpful.
Yeah, it's just that I ran into a few people that have the stories as well too. So I put across that we have a lot of people that know what they're doing, that do care, and have the people's best interests at heart, right? And all of these people that are doing this work also have family members and stuff like that are all affected the exact same way. So I try to bring it home that way. But thank you very much for trying to answer my question. I know it's a very difficult question. So thank you.
Yeah, no worries. And I think one thing I will add is it doesn't help that I think a lot of the rhetoric that around folks that are encouraging people to get vaccinated is very, there's no real nuance in some of that messaging. It's get vaccinated or don't type of thing. When there is, I think, some reasonable gray area that people can feel concerned and nervous. And, I'm in the healthcare system, and it's easy for me to say like, oh, a vaccine, no problem. But there's a lot of privilege in the information that I have access to and just my own experiences. And so, yeah, it's creating that space is difficult. And yeah, I hope that, in your interactions with those folks, Dan, that you're able to help more and more folks feel comfortable and opening them up to that conversation. Because I think that's the biggest part. It's bringing them to a place where they'll at least talk more openly about it. And then you can, and then I think that's when that convincing kind of begins to happen.
Yeah, I try to use my incentives to be from the positive method as opposed to the negative, like telling them about what bad things could happen. One of the things that most people are worried about is their lack of facts and sureties that this thing, if you do this thing will happen. So if we can present them with the high percentage rates of not being hospitalized, low percentage rates of actually having high or severe illness, these are things that we can actually state for a fact, and they can grab onto it. So I try to put across from a positive point of view in that way.
Yeah, that's an excellent way to do it. And I know one thing that also works for me is sharing my own experience receiving the vaccine. as well. Sort of helps to assuage some concerns, especially as being someone who, even outside the COVID vaccine, has reactions to vaccinations. I think it helps also provide some assurances that, oh, it is okay to take, and it makes also that conversation a lot more human.
I was also hesitant too. I was one of the very last in my group to get on board to take it, and I wanted to be well informed and make a conscious decision. And so I had that too when I speaking to these people that, yeah, you want to do the investigation, and knowledge is power, right? And the more knowledge I got, the more I was sure I was doing the right thing.
Absolutely.
All right, thank you.
Thank you, Dan.
Now I understand that Nina has joined us, and Nina was one of our panelists. So Nina, if you would like to join our conversation. No, you need to turn up your mic.
Okay, I'm not sure where my built-in mic is. I'm sorry.
There we go. We can hear you.
Okay. Wow. All right.
See?
Oh, okay. It worked somehow.
Yes, it works. Okay, everyone, Nina would like to share her experience with COVID. And I know, Nina, you weren't part of the discussion, but I want to give you, and I hope your husband is with you. Okay, great.
All right. I apologize for that. I was having such technical hiccups.
That's fine. You're here now, and that's all that matters.
Okay, cool. So, thank you. Easter weekend, I got the big C, shall we say, COVID, because somebody had come over and I didn't know they had it. I didn't even know they had a cold. And essentially, I got a test from the pharmacy that Kevin had gotten, and he said, test yourself. So I did on Be My Eyes, and then they said that it looked like a positive test. And it sounded to me like the volunteer was, he said, because she said it looks like a pretty sure positive test, that I kind of was like, oh, right, well, I wonder if I should doubt you at some level. But then I informed people at a pub event I'd gone to, and they basically had said 10 days later to people that to watch out for symptoms. But the symptoms I had experienced were a cough, a cold, sore throat, a lot of fatigue. Sometimes I still have fatigue suddenly, and that's not just due to diabetes. I mean, that's a symptom of diabetes, yes, but this is like really like I gotta go have a nap now, that kind of feeling. So it's not gone away for people. It can still come back and bite you, COVID can, if you've had it before. And I didn't have a fever, but it was very mild symptoms at first, but it was a cold and a sore throat and just it was hard isolating. There was a stigma involved, and I had gotten vaccinated 3 times, and I had been mostly wearing a mask around the person that had come over. So yeah, I've just been telling about how insidious this thing can be. So if you guys can, please remain vigilant with sanitizing hands, aka soap and water, and eating well, and just that's all I got to say with that. Is everybody there? Hello?
Yeah, we're here. Thanks, Nina. Christine was just standing up for a second. Go ahead, Christine.
If Kevin would like to share his story.
Yeah, I'm right here. Can you hear me okay?
Yes, we can.
Okay, great. I didn't get tested like Nina did. But the symptoms that she described that she had, I came down with about a day or 2 days later after after she came down with her symptoms. And basically with me, it was my throat. My throat got very sore, and I experienced a lot of runny nose, that sort of thing. And so I chose not to test myself. I thought, okay, if she's got it, then there's a pretty good chance that I have it. And I just made the decision, okay, I'm going to self-isolate. I'm not going to go anywhere. And I think the real disappointing thing about it was Easter, very important time of the year as far as our calendar is concerned. And we just couldn't do the activities that we would normally do over Easter season. And we had to stay home, and I chose to do it. Nina chose to do it. And but it's just humiliating sometimes when people don't take this virus very seriously. I've encountered people in my travels in my life who think, well, I'm healthy, I'm not going to get it. And I do actually know someone who, for whatever reason, has chose not to get vaccinated. I met her a week ago. I was out in Brantford, and I just find it very, very frustrating because I think this is a very serious illness, and I think people, whether they get illnesses from it or they don't, they can pass this on, as you all know. And I think it's just upsetting to me that people would rather listen to the voices of those conspiracy people out there who tell all kinds of lies, in my opinion. But I think I think people are just really wandering away from common sense, and it's just disappointing to me. That's all. I'm glad I took the precautions that I did. I wear my mask in most places. I don't care if people look at me kind of funny, like, what's the matter with you? Like, as far as I'm concerned, I feel safe. I'm doing the right thing. So thank you for your time.
Nina, you didn't get a chance to introduce yourself to the audience. I know who you are, but you did not share with us who you are.
Okay, I am a member of AEBC, joined since December. I had joined a long time ago when I was in university, and then I left for a while to do other stuff, and then came back. And okay, I hope to keep working with you guys. Thank you for letting me be here. I've got a couple of university degrees in various subjects, and I have a radio degree. And yeah, I have had COVID before, just that Easter weekend. And yeah, I had all kinds of stuff planned that weekend, and I couldn't do any of it. I was supposed to read a recital on Good Friday, couldn't do that. Saturday, I was supposed to go to one of two gatherings, couldn't do that. Sunday, same thing. And yeah, so that's why I wanted to speak about COVID, but it's destructive.
Okay, well, thank you so much, Nina and Kevin. Do people have questions for Nina and Kevin?
While we're waiting for those to come in, I have a question for Rob that came through the chat. Rob, you mentioned that there might be a more Omicron-specific vaccine coming soon, I think maybe in the fall. If people become eligible for fourth dose boosters, should they get those as soon as they're eligible, or might it be worth waiting to see if a vaccine that is more Omicron protection becomes available?
Well, this is I don't think there's an easy answer. I mean, certainly if you feel like if you're in a category of individual where it's recommended that you get a fourth dose, then it's probably in your best interest, especially if but if you want to wait, that's certainly your decision as well. I mean, my personal thoughts are that I think that it will probably be best to wait for like an Omicron specific dose, assuming that it gets approval. Moderna's announced this, but it has to go through all the regulatory approval to make sure that it's as good as they say it is. And I think probably that will be my preference, to get something that's very specific to what's circulating a little bit closer to the fall, so that I have good protection going into the respiratory virus season. But again, I can only speak for myself, and I don't want to. Decision to get a fourth booster dose for people that qualify is obviously a personal decision.
Craig, did you want to add anything?
No, I'm not sure that I have much to add. I think, much like Rob said, it's a bit of a waiting game to see if it gets approved, when it gets approved, and I think that timing will be key in decision making for most.
Thank you. Robert, would you like to unmute to ask your question?
Yeah, what's the doctor's take about monkeypox?
Good question.
So, well, don't get it. That's if I can recommend to you one thing, don't get monkeypox. So that's this is something that obviously this is the background for anyone, that this is a virus which has been seen historically in parts of West Africa. So another zoonotic virus. So it makes a jump from an animal species into humans. We've seen what people have predicted for, in the scientific community for decades, that these viruses don't respect boundaries, but are happy to infect people. And when people, travel to parts of the world and then come back, they can then spread it. So I think this is something that we definitely are keeping a watchful eye on it. The case numbers right now are relatively small. The good news is we have a vaccine, and there are some antivirals as well that can be used to treat people. So right now, I think the emphasis from the public health standpoint is just focused on identifying cases and sort of tracking the outbreak to make sure that it doesn't become any more widespread than it has to be. So it's something where we, I think we need to be cautious, but I certainly not the time to panic. The good news is a lot of the measures that we use already for COVID will also protect you against monkeypox. Good hand hygiene, staying home when you're sick, a mask to prevent droplet transmission, and obviously social distancing. All those will also protect you against monkeypox.
What's the health restrictions? Will it be like COVID?
You're asking, are they going to put in like lockdowns and that kind of thing?
Yeah.
I mean, I think is incredibly unlikely. Of course, I'm not in a position where I can really say what public health is going to do, but I don't imagine that there will be any sort of lockdowns or any of the major restrictions that we have with COVID. It's a different virus, so our response to it will be different than COVID.
I haven't got vaccinated against smallpox, but I got vaccinated against shingles. So is that the same thing as smallpox?
No, it's confusing, because they're all pox in it. So chicken pox, what you've got is the vaccine that protects against what's called the varicella virus, which causes chicken pox when you're a kid and shingles when you're older. Most people under age 50 probably haven't had smallpox. My parents have, because they're from that generation. But so nobody probably likely has the smallpox vaccine.
I'm over 60, so.
Okay, well, maybe you were lucky enough to get one. I don't know, but the Shingrix vaccine and the one that protects against varicella chickenpox, a completely different virus than monkeypox and smallpox.
Yeah. Okay.
Another question from the chat, and everyone, please feel free to continue writing them in to me. How long after a COVID infection are you somewhat protected from getting reinfected? Is there a period of time where it's unlikely to get reinfected with COVID?
So generally, following infection, usually your antibody levels are pretty high for about 90 days. So usually within that time, you're pretty safe from infection. There's emerging data coming out saying that people who get vaccinated and then have subsequently been infected with COVID probably will have better long-term immunity and a wider breadth of an immune response against other emerging variants. So I guess that's a bit of a silver lining if you were unfortunate enough to get a infection. But generally
You cut out just a bit at the end there, Rob. Generally 90, and then we lost you.
Yeah, sorry, my internet connection's been spotty all day. 90 days is about how long you probably are protected against reinfection, but that's like a population average. It can vary for certain individuals.
Thank you so much. That is the last question that I have in the chat. Are there any other questions? Please feel free to raise your hands and unmute or put questions in the chat. And Christine, I'm not sure if you have any additional questions you wanted to ask the panelists.
No, I think this has been a really good conversation, really good discussion. I appreciate everybody's time.
Yeah, it was a pleasure. Thank you for inviting me.
Thanks so much for inviting me. It's been a pleasure for a captive audience to listen to my ramblings.
Hi, Kevin has a question.
Can you folks hear me okay?
Sure, go ahead, Kevin.
My question is, I heard on the news this week, yes, the news, that mask wearing supposed to be ending in most public places. I don't know if you've heard that or not. Anyone from public health to the government that maybe mask wearing should be extended a little bit more?
So I can hop in. I think my experience with public health, and I think at large is that they have sort of policies that they're going to be rolling through, and I know that it often differs from some of the public sentiment, especially around mask wearing. I think while they'll probably still be pushing through the dropping of that mandate, it's important to remember that a lot of sort of businesses and services will still have, or they're allowed to and open to having their own individual mask mandates. And I think ultimately it also comes back to your personal comfort levels. I think, Kevin, just like yourself, I also wear my mask out and about just because it makes me feel comfortable and safe and protected. And I think that there are a lot of folks that will continue to do so as well. And I think it's important even that becomes just naturally a part of our culture as well. Unfortunately, I think perhaps they're aware, but what the goings-ons of public health and the policymakers are sort of opaque. So unsure what are all of the considerations that they're taking into account in pushing that through. But I think that the fact that they're going to drop it probably won't change. And so that creates individual considerations for all of us, as well as just trying to keep an eye on what some of these businesses and service providers choose to do, especially the ones that we frequent.
Thanks, Craig. And yeah, as we mentioned before, just because the mandates are going to be dropped doesn't mean that individual businesses and medical centers and community members aren't going to institute their own policies and procedures around masking and protections.
Are there any other questions?
We had one question in the chat about how the COVID-19 vaccine works. I know that Christine, you're going to send out some resources, and I have sent the person the link to the City of Toronto page, really breaking down exactly how it works. But I don't know, if, Craig, if you want to share a quick vaccine blurb on how they work.
Yeah, I mean, an easy way to think about it is that the vaccines essentially train your body to recognize the virus and to disarm it before it does any harm. That's in a nutshell how they all work. Now, what's important to note is that the COVID vaccine specifically doesn't contain any live virus. I know some of the influenza vaccines previously, how they would work is that they would take a virus, they would disarm it so it doesn't get you sick, and they would inject it into you. And that's how it trains your body. That's not the case here. Instead, what is being injected is mRNA, which are the blueprints to what these things look like. So it's equivalent of like injecting a wanted poster for the virus into your body. Your immune system will then be able to recognize from this outline what the virus looks like, and it'll be able to very specifically tackle that virus if it enters your body through whatever system, whether it's through your nose or your mouth or any sort of mucous membrane, rubbing your eyes, which I do all the time, unfortunately, so I'm terrible at it. And so that's essentially how it works. And every time, both doses as well as the boosters, what they do is just to basically remind your system what this thing looks like, so that it can continually be prepared to tackle the virus if it does happen to enter. That's my quick Cole's Notes version of how mRNA vaccines work. I don't know if you want to add anything, Rob.
That's great. I think Rob may have dropped off the call.
He actually had to leave. He let me know that he had an emergency that he had to deal with.
Thanks, Christine.
Yeah.
And that's the last question that we've received.
Okay, well, I want to thank everyone. Craig Madho for his time, and Nina and Kevin Avery for their time and sharing their stories, and all of you for all of your comments and your questions. This has been a really lively discussion. And on behalf of the Alliance for Equality of Blind Canadians Toronto chapter, thank you so very much for attending. Next steps, you're going to receive a resource document, which is going to include a reference that Dr. Rob Kozak made to a couple of things, and some presentations on COVID and some updates from the City of Toronto. And I'm also going to be asking for your feedback on this town hall and anything that we could improve for the future. So you'll be seeing that in the coming days. So thank you so much for coming, and have yourself a great afternoon.